Well, welcome to Nursing 803. This is the first lecture. It's sort of a hodgepodge just to sort of get you in the mood for a fun semester. The thing that I noticed when I was studying pathophysiology is that I kept coming up with the same things over and over, right? We kept studying the same kind of things every time we looked at a new body system. And those things included things like infection, autoimmune disease, ischemia, all sorts of things like that. So I have put together a little introductory slide deck to talk about some recurring themes in pathophysiology. I had a guitar teacher once who taught me that if you know 4 chords, you'll know 1,000 songs, right? And that's true in pathophysiology too. If you know 8 different disease types, you'll know 1,000 diseases because we keep seeing these things over and over and over again. So we're going to talk about inflammation a ton this semester. We're going to spend a good deal of time this morning or today talking about it as well. We'll talk about methods of cellular adaptation. We'll talk about some genetics issues and etc. So let's start with talking about the lifespan of the cell. You know, cells don't all last forever. And there are 2 ways that cells die. They either die in a very orderly process where they are selected for extinction, and then all of those materials of the cell are reused. We call that apoptosis or apoptosis. Back when I went to school, we just called it programmed cell death, but then they needed a fancy word for it so they could get more research dollars, I guess. And so now we call it apoptosis. That is a normal process, and it is the way that cells are supposed to die, okay? The other way is very messy, and that's called necrosis, and that's an unplanned event, and that's when you have something from some cellular death or tissue-level death from ischemia or trauma or infection or whatever, all right? So, again, 2 ways to die. The very neat method on the right here, which is apoptosis. And when you have apoptosis, it's all orderly, and all of these organelles then that were part of the cell before now get recycled. They get recycled and used by the body in other ways. The other messy way, though, is this necrotic death. And when that happens, the cell contents just become pus, right? The cell gets eaten up by white blood cells. Those white blood cells eventually die. They turn into pus, and all that material is lost. So we're going to talk a lot about different tissue beds that die as a result of these processes that we're discussing here. Genetic disorders, we learned about them always. To me, they've always been a little off-putting to learn because there's so many levels to it. But I think this image helps to classify it so that I can organize it in my head. And so we have these chromosomal disorders. Well, when you have a chromosomal disorder, then that is really the basis of a lifelong disease. Or sometimes a chromosomal disorder leads to a very shortened life, or perhaps not sustainable. Life is not sustainable with particular chromosomal disorders. Now we have autosomal chromosomal disorders, we have sex-linked chromosomal disorders, and then we have any number of subclasses from there. The single gene disorders we talk about with an autosomal type or a sex-linked disorder. And so these are the classic disorders that you think of when you think of things like cystic fibrosis and, you know, those autosomal disorders. And then we have multifactorial disorders, and I would say that these are really the most common genetic disorders that we see, where there's a genetic predisposition to a disease. In my world, you know, of cardiovascular disease, it's coronary artery disease, right? It's 2024, 25, 28, whatever it is. We today don't know what causes coronary artery disease. It sounds crazy, right? We have no idea what causes it. We know what puts people at risk. And we know that when people have a genetic predisposition, and then they add in things like tobacco abuse and dyslipidemia and diabetes, etc., those all increase the risks. So we can't always prevent coronary disease, but there are some genetic disorders over here in the single gene disorder category where people are born without the ability to have circulating cholesterol. Amazing, right? And in fact, those are the people that were studied in order to come up with the treatment of the PCSK9 inhibitors. When the body doesn't have PCSK9 bodies in the liver, then the cholesterol, the serum cholesterol, is almost zero. I mean, it's very, very low. And so those people do not develop coronary disease. That's interesting, right? So again, back to the multifactorial disorders. These are things like coronary disease that people have a genetic predisposition to, but not a single gene disorder that causes people to be at risk for a disease. And then with certain environmental factors, like sitting around and not exercising regularly, like smoking cigarettes, etc., that cause the disease to evolve. All right. And then there's some acquired somatic disorders, and we'll talk about those things later. The thing that and by the way, this is the kind of stuff that we just discussed. Listed here are drugs used in pregnancy that can cause issues. So for instance, ACE inhibitors are teratogenic, and they can cause severe disability or abnormal growth and development in the second and third trimesters. We don't really know of any downside of exposure during the first trimester, but still, when somebody's pregnant, we discontinue ACE inhibitors because they are known teratogens in the second and third trimester. And why push our luck, right? Although nobody knows of any teratogenic effects in the first trimester, you certainly don't want to be the prescriber who's first to discover them, right? All right. Somatic mutations then are those things like lung cancer, diabetes type 1. These are things where there is a mutation of the genome that causes development of a particular disease. And again, we're going to talk about that throughout the semester. The last thing, and I think the most fascinating thing, is the story of gene expression. And of course, we have a fancy word for this, right? That fancy word is epigenetics. Epigenetics you may not even have heard of before. But what that means is that somebody has a genotype, right? Which means that they have the genetic code to have a disease. And yet they don't have a disease. How can that be? If genetics tells everything, why would somebody have the phenotype, have the genetic code that makes an abnormality, but they don't have the trait? They don't live that disease. Well, the reason can be epigenetics. So not only is the code of the DNA important, but also which genes are turned off and turned on is important. And that's what this epigenetic code is about. So with methylation, we will see different genes turned off and turned on along the DNA strand. And a very good example that will get you thinking is linked here. You can click on the Dutch hunger winter of 1944. During this time, the Dutch were being punished by the Nazis for coming out against the war and against Nazi aggression. And so they decided to just stop shipments to the Dutch. And when they stopped the trains, everybody there died, or at least had famine, severe famine during the winter of 1944. And people who survived that, pregnant women in particular, who survived that had terrible effects from it. But not only was it found that the pregnant women had terrible effects, their fetuses were born, they were smaller, right? No surprise there. But guess what? The fetuses then developed a epigenetic code that made them have a tendency toward obesity. Isn't that fascinating? Well, it's even better than that, because the generation after that generation still retained the same epigenetic code. And so there is power in the epigenetics, and we are just now beginning to unleash some of those things for patient good. All right, so genetics is another thing. Again, really keep your ear out for developments of epigenetics. It's going to be interesting. Neoplasia, of course, we see this repeatedly in every organ system that we deal with. Everybody has a cancer of some kind. Interestingly, the heart is very, very rarely affected. And the most common heart neoplasm is actually a benign myxoma that happens typically in the atrium and is non-cancerous, just has to be removed along with the surrounding tissue, and they live a long, healthy life as long as they don't have a stroke first from the myxomatous disease. So what are the distinctions between benign and malignant tumors? Well, classically, they are these things. Benign tumors tend to be slow growing. They are well defined and encapsulated. So if you look at a chest x-ray, for instance, and you see a tumor on there, if it has very defined edges, brain tumors are another one, right? You see that on imaging. If it has a very defined outline, then the chances are that that is an encapsulated tumor that is benign. If you can't draw a line around where the tumor starts or tumor stops and new tissue, good tissue begins, that's very likely to be malignant. Because malignant tumors tend to be invasive, right? They tend to finger out and get to normal tissue and expand without any containment. Benign tissue also tends to be well differentiated. That means when you put it under the microscope, it looks like the tissue that it comes from. So in the case of atrial myxoma, for instance, it looks like the supporting structure that it comes from. And poorly differentiated or anaplastic tumors are very hard to determine. So sometimes people have a lung tumor, for instance, and it's poorly differentiated squamous cell or whatever. It's really hard under the microscope to know where that tumor originated from. Is it primarily in the lung, or is it something that came from, the liver, for instance? It's very difficult to differentiate those things, and that is a characteristic of malignant tumors. Benign tumors rarely have necrosis, but necrosis is very common in malignant tumors. And that makes sense, right? Because the body's fighting those malignant tumors. They are not programmed. You can't program a cancer cell to stop growing and reproducing and die. It is very common for necrosis to occur. There's the mitosis, right? So benign, going along with the slow growth, has a low mitotic index, but rapidly growing malignant tumors have a high mitotic index, right? They are dividing very, very quickly. And then finally, benign tumors really don't metastasize. Again, they're encapsulated, they stay put. They may cause symptoms. If you have a benign tumor in the brain, they get slowly bigger over a very long period of time, and that means you can have really giant tumors, but they don't metastasize. Different for malignant cells because they eat their way into the bloodstream and they can spread through metastatic processes. There are some characteristics of these tumors or of neoplasms, I should say, and cancer cells in particular that I want you to know about. So let's talk about some of those things. First of all, autonomy is a big deal, right? Normally there's intercellular signaling that tells a cell whether it should get bigger, get smaller, stay the same, divide, apoptosize, I don't know, is that a word? Be programmed for cell death. Those cellular signals and also autocrine signals, the signals from the cell itself knowing that it's time, that it has to end its life, those things are easily recognized by healthy, normal tissue cells. But cancer cells are autonomous. They don't have a king, right? They don't listen to anybody. They do their own thing. And not only do they do their own thing in the tissue bed, but they can also do their own thing in suspension and in individual means. So cancer cells don't have this contact inhibition. When they divide, they continue to divide without regard for the autocrine without regard from the paracrine signals from the other neighboring cells. They just keep going crazy, right? That's what cancer cells do. As opposed to normal cells that tend to layer out. They go in one layer. They know they aren't supposed to go stack on top of one another. Secondly, when normal cells are suspended, they tend not to grow. If they're in this soft agar and not attached to other cells, they don't grow and divide. That's not true with cancer cells because they are anchorage independent and they can just keep going without regard for any of those cellular signals that they should respond to. So these are some of the important things. Another really big one, I should say, is immortality. These things do not die. They don't respond to p53 signals, which we'll talk about later. They don't respond to the other signals from the body telling those cells that they should stop dividing or undergo apoptosis. And that's why cancer cells are such a problem. Carcinogenesis is the act of turning on the proto-oncogenes, right? These are the genes that tell the cell that they are going to become cancerous cells. And that causes hyperactive growth, and that's oncogenesis. That's when the carcinogenic process begins. In order for that to happen, there has to be mutation of particular genes, and that mutation has to happen about 7 times before tumor growth begins. Okay? Another characteristic of these tumor cells is detachment and invasion, right? So some of these tumor cells can break off and travel in the bloodstream or travel nearby somehow else. And then when they find a blood supply, then they can attach and invade that surrounding tissue. So we're going to talk a lot more about that stuff as the semester goes, but those are just some of the highlights that I want you to keep in mind as you think about some of these other systems that we'll be discussing. Inflammation is huge. Every single time we talk about a new body system, we talk about diseases that either are caused by or associated with inflammation. Now, inflammation's good. And by the way, I think we should not treat inflammation acutely. So if I was watching a game last night. If a football player goes down and they hurt their knee, should we put ice on that right away? I don't know. What are we doing there? Well, we're slowing down the inflammation. Well, to what end? Isn't inflammation good? Yes, it is. So I have a habit of not treating fevers because I want that fever to cook it out, right? Our body is designed to work using these inflammatory tools. Why do we want to tie one hand of our immune system behind its back? We don't. We want to use the immune system for all it's worth. And there's an article or a chapter that I'm going to have you read specifically about that by an author who's a CHOP. All right, so the purposes of inflammation are to get white cells to the site so they can do their work, to coordinate all these other components of the immune system. We want the infection or the process to be walled off. We want to take away the waste products and we want to bring in healing products for the tissue. So how do we do that? Well, the inflammatory process really starts with cellular injury or some invasion of a pathogen. And then that does these three things. One, it causes degranulation or explosion of these mast cells, right? So these little somal bodies contain histamine, and that gets released. And so this release of cellular products like histamine is part and parcel to this beginning of the inflammatory process. And in doing so, it activates these plasma systems, complement, clotting, kinin, and all these things together we give a name. So let's talk about that in a bit. One of the effects of all of these things, complement and kinin and the release of histamine and all that jazz, is we get vasodilation, right? We get more blood flow to that tissue that needs it. Then we have vascular permeability, and this is where it's easier for the white cells to get out and the red cells to get out, form clot there, wall off the infection. And along with that comes edema, because there's plasma that's leaking out that has all of these clotting factors attached to it. And so that happens and causes edema, right? The other thing that happens is that when these white cells do their thing, they form pus, right? And then eventually the pus gets picked up and carried away, or sometimes not. Sometimes we have to debride it to get rid of it. Again, thrombosis happens. We have to have clotting, either intrinsic or extrinsic to the vessel itself, and that causes healing to take place. And then finally, all of those things together, including the kinins and whatnot, cause stimulation of the nerve endings, and that results in pain. And that's why when you have cellulitis, the skin is just really raw. And it's why when you have a broken ankle, the inflammation causes such pain. Yes, the ankle's broken too, but all that inflammation really makes it worse. And that's to help protect you too, right? You know that when you have terrible injury, that that pain will help limit your activity. There is a genetic condition where people can be born without nerve endings, and they have a horrible time knowing when they're injured, and so they may continue to exercise or play on broken bones and damaged tissue. Complement is one of those things that is very challenging to understand, partly because of the way we name it, right? Can you think about memorizing all of the complement activities that are associated with C2A4B? I mean, no, we're not doing that. We're not getting to that level. But I do want you to understand essentially what the complement system does. So through all of these very complex mechanisms, we end up causing bacterial death, and some of these things identify the bacterium and mark it for death. And we also have chemotactic factors that get white blood cells to the site that needs them. And complement is what we have to thank for all those things. The clotting cascade, look, there's a whole lot of detail in the clotting cascade that we're not going to bother with, especially for this part. What I want you to know is that factor 10A is really where these two intrinsic and extrinsic systems come together. And when the factor 10 is activated, that's what the A stands for. It stands for activated. When factor 10 is activated, then all of these things come together to cause this prothrombinase complex. And then thrombin gets separated and fibrinogen takes over and causes the clot to form. All right? If you memorize this, that would be fantastic. Just from 10A on, right? Just from here down. That would be fantastic because this is the part that you really need to know about. All right? By the way, you don't have to memorize it for the quiz this week, but the next step is the kinins. The kinins largely are responsible for producing pain, all right? So the prekallikrein and the kallikrein then give rise to eventually bradykinin. And bradykinin causes vasodilation and vascular permeability, and along with that, again, inflaming the nerve endings and causing pain to occur. So you're going to learn about bradykinin when you talk about ACE inhibitors, because one of the bad things that, not bad, but one of the annoying side effects that we have with ACE inhibitors is that sometimes they have such an effect on bradykinin that they cause, and bradykinin is highly concentrated in the lungs, that it causes these things to occur, and then you get a cough that never goes away. And so we stop the ACE inhibitor, switch it to an ARB, and then you're good to go. But this stuff takes it takes a hit and means that we have to switch the drug. All right? But the part about the kinins that I want you to know is that they are really responsible for pain in the inflammatory process. Now, we talked about kinins and the clotting cascade, and we talked about all these other things. Let's take all of them and just reclassify them as cytokines. So cytokines are really just all of those things that we've been talking about. The interleukins, the tumor necrosis factor, the prostaglandins, all those little subcellular chemicals and messengers that are important in the inflammatory response and the immune response. So again, all of these things that we've talked about, complement, clotting, kinins, all those things together we can classify as the cytokines. And that's important because in certain diseases, and by the way, I'll give you a hint. What disease do you think would have been talked about in the New England Journal of Medicine in December of 2020? COVID-19, right? The big cause of all those deaths initially was not from the infection itself, but rather from the cytokine storm that accompanied it. And so I don't want to go into all the details of cytokine storm, but we will later in the semester. Just suffice it to say that all of these signals and messengers in the body have a very important role, but they can overdo it too, right? They can overdo it. On the football field, you may want to have a really aggressive linebacker, but they can overdo it and hurt your team with penalties. Same thing is true with the cytokines. They have a job to do, and when they get released into the wild, they can do their job, but they can overdo it and hurt you, not with penalties, but with downstream effects of those things, such as ARDS, for instance, right? It can cause such terrible effect on the lungs that the lungs are overwhelmed by the cytokines, and then you have a very difficult time oxygenating and ventilating. All right. These are some of the clinical effects of cytokine storm. Again, I don't want to go into real detail about this. We talked about mast cells before. These are some of the effects of the cytokines and histamine and all these other things, and how they affect or are affected by the release of histamine. And this talks about the role of histamines. And again, I don't want you to memorize this slide for this week, but just rather have an appreciation for the complexity and the wide range of effects from histamine. Okay? Another part that we don't talk about very much is bringing out the fats. Well, remember, the cell membrane needs fats in order to maintain its structure and in order to repair itself. And so there's quite a bit of activity on the fats in the body that take place during the inflammatory process. And those are illustrated here. This is a little more detailed than we are ever going to get, but again, I just want you to have an appreciation for the magnificence of this body. If you can't learn anything about inflammation except this slide, I'm fine with that. Know that this slide is sort of an overview of everything. It tells what happens at the arteriolar level, at the capillary level, and at the venule level with the inflammatory process. So there's arteriolar constriction to limit blood loss, right, at the site of the injury, at the arterial side of the injury. And then there's this transudate or leaking of the plasma that comes out into this tissue as a result of the histamine release and the prostaglandins that tell the body to release these things into the bloodstream. There's leukocyte adhesion that happens right here, and that has effects on the vessel wall. And then there's platelet aggregation that happens to form clots, so you stop bleeding to death. And then the red blood cells lay on top of that, and they get thrombin thrown on top, and fibrinogen, or fibrin, sorry. And then you have the macrophages that infiltrate the area to pick up all the remnants of this terrible battle and clean up the battlefield. So if that's what you learn, good. I hope you learn it all. All right. Chronic inflammation is something we don't love. I love acute inflammation because the body's doing its thing. It's doing exactly what it was programmed to do and what it was built to do. But chronic inflammation is not good. So when this happens after 3 months, then that's not what we want to see, right? There's persistent acute inflammation with the histamine release and degranulation of the white cells and all that. There's neutrophil degranulation and death. There's lymphocyte activation that continues, and that's really a big part of the problem. And then there's fibroblast activation. And fibroblasts, sounds like fibrinogen, which it is similar to, but it's all that fibroblast activation becomes scar tissue. And that scar tissue, the fibroblasts, lay down and make the tissue no longer as it's replacing the normal cells there, but it's also sometimes making that tissue less, what's the word I want, but it's also making the tissue less elastic. And so we see this in things like, again, forgive me, but I know cardiology better than anything. We see it in the heart when somebody has a heart attack or when they have chronic heart failure. This chronic inflammation is what lays down all those fibroblasts or scar tissue in the heart. And those scar tissue cells don't allow the heart to, they don't contribute to contraction. And when you fill up the heart in diastole, they don't let it expand to fill very well. And so those are some of the things that happen. Anytime you have scar tissue in normal tissue, it becomes more firm. Another way to think about it is chronic liver disease. When the liver is replaced by fibroblasts, then it becomes less flexible, less elastic, and the pressures in there build up and push back into the gut through the portal system. That's what gives you portal hypertension. So chronic inflammation, always bad. We don't want it. We want to make it go away. And we want to have normal tissue instead of scarred tissue. So what are some of the systemic manifestations of inflammation? Well, fever. And by the way, I'm not talking about chronic inflammation. We're back to local acute inflammation. Fever, right? So the fever is caused by those pyrogens, some of those cytokines that go to the CNS and tell the brain to raise the temperature. There's also leukocytes that are running around in increasing numbers, and there's plasma protein synthesis that happens that are acute phase reactants. This is an important phrase to learn. Acute phase reactants. These are really things that we don't want in our bloodstream, but they are part of the process. When tissue dies, or when it's ischemic, for instance, you can have these acute phase reactants that build up and can cause mischief. We also see things like amyloid, for instance. Again, another heart problem that we see. Fibrinogen can be increased, C-reactive protein. All those things are acute phase reactants, and none of them are really good. And they are generated then in response to these inflammatory cytokines. Okay? We're going to talk a lot about those things later on. If you don't fully grasp it, no problem. This is really just an introductory level discussion. So infection, everybody is familiar with all these things. You know that, I'm sorry about that. That S is misplaced. It should be up there. So we have things called prions. These are terrifying. These are the things that cause CDE or mad cow disease. And the funny thing about them, not funny but funny is that they are not alive. You know, viruses have a protein shell and they have DNA or RNA inside them, right? Prions don't have DNA or RNA. They are just a protein shell. It's terrifying that a protein can cause that kind of damage. It's really frightening. Creutzfeldt-Jakob disease is the human version, and it's a horrible thing to see. It just causes destruction of the CNS. So we know about prions. We hope not to see them very much. Viruses, we know, there's HIV. There's all sorts of other viruses out there, RSV, and COVID-19. May have heard of that. We have fungi, we have protozoas, and we have parasites that can all cause mischief. So the process of infection is 4 steps. First, there's colonization, and that's where the organism exists in these reservoirs in the environment. And then there's some human-to-human transmission that occurs, and now that invasion of the infection penetrates the host and begins to evade the defenses, and then the organism multiplies, whether that's a virus that takes over the cellular machinery and reproduces that way, or whether it's a bacterium or a parasite that reproduces in its own way on its own using the supplies, shall we say, of the human body. The fact is that they are multiplying and causing problems. And then finally, there's spread of the infection. It migrates through the tissue. It may go into the circulatory system, in which case we call that bacteremia if it's a bacterium. It can get caught up in the lymph system, which is kind of the sweeping up of bigger molecules in the interstitial space that's not attached to the veins. And that process is, that four-step process is the process of infection. The 4 stages are the incubation period, and this is where the cells have to, or the organism, I should say, whether it's a virus or a bacterium or a parasite or what have you, has to multiply and do its thing. Then there's the prodromal stage, which is the initial occurrence of symptoms. The invasion period, which is where the immune and inflammatory responses get fired up. And then the convalescent period, which is where the symptoms decline and hopefully you get better and recover. But sometimes this reactivation can happen, and we know about that with COVID-19, don't we? Right? All right, so here we go again with those mast cells. These mast cells are an important part of the inflammatory process, which is in part a component of the immune response, right? So we talk about mast cell degranulation and all the benefits that it brings with it, including the chemotactic cytokines. IL-4, for instance, increases B cell proliferation and antibody production, right? Antibodies are come from the B cells, which are stimulated by IL-4. That's just one example, but there's plenty more to look at here. And then again, we have the cytokines. They have all sorts of effects all throughout the body. The complement system, the kinin system that we talked about ad nauseum before, the coagulation system. And then finally, they result in opsonization, right? Opsonization is where there's recognition of that foreign invader, and then something sticks to it, like the white blood cell. And then engulfment happens, where the white blood cell engulfs that organism, and they take it inside. It gets self-contained in a phagosome, and then the phagosome joins up in the cell with lysosomes, and those lysosomes are meant to destroy the bacterium, and that's what happens when phagocytosis occurs. It's a beautiful and very functional process that our maker has come up with, and it works. All right, so ischemia, we all talk about it, we all know it. Remember, it's a lack of blood flow to tissues or cells that results in the injury or death of cells, or maybe just a hypoxemic response, right, which can cause its own problems. So ischemia is what happens to the tissue. Tissue is made up of like cells, right? So in the liver, for instance, they're hepatocytes. And so ischemia affects the tissue bed, which is made up of cells. And so that cellular hypoxia results. And that causes the mitochondria to fail. What do the mitochondria do? They are the powerhouse or the energy store for the cell. And when that mitochondrial failure occurs, then you have decrease in ATP production, right? ATP is the cellular economy. It's what makes things happen. It's the dollar unit of the cell. And so when that fails, then calcium pumping fails, and that leads to calcium overload in the cell, and that leads to free radical production. As free radicals are produced, then cellular death occurs. And the first thing that happens in cellular death is the sodium-potassium pump fails. When that happens, the cell swells and bursts, and then the necrosis process takes over. There's some other things that can happen in ischemia, though, too. There may be all these things that happen temporarily, but then when blood flow is restored, then we get immune cells coming in, and they may evaluate the scene and determine that those cells that were ischemic for so long need to be eliminated, and that leads to cellular death sometimes as well. Okay? Stress. Remember that cortisol is the primary stress hormone. It gets activated by ACTH, and if you don't understand how glorious and magnificent the endocrine system is, you will by the end of this course, because I think that it's important for you to understand how the hypothalamus interacts with the pituitary and the end organ, such as the thyroid or the adrenal glands in this case. And at the end of that, the thing that manages it is this very elegant system in biology. Probably, I mean, it's certainly got my vote for the most elegant biological system of the negative feedback loop. We're going to talk about that so that you have a really good understanding of it by the time we're done here. Okay? So anyway, cortisol then gets activated by ACTH. That stimulates gluconeogenesis, which increases the blood glucose level. There's anabolic effects in the liver, catabolic effects on other tissues. Remember, anabolic means building up, catabolic means breaking down. And then there's lipolytic effects in some parts of the body and lipogenic effects in other parts of the body. That's why you get that weird moon face and the buffalo hump with chronic cortisol conditions. And then there's this powerful anti-inflammatory and immunosuppression that occurs with cortisol too. So that is the stress hormone. Cortisol is the stress hormone. Never forget it. Again, sorry about the catecholamines ES thing there. But you already know about adrenaline or epinephrine and noradrenaline or norepinephrine. They are also released from the adrenal gland, but in the middle, the medulla. All right. They hit alpha adrenergic receptors and beta adrenergic receptors to stimulate vasoconstriction for the alpha, and the beta stimulates increased heart rate, increased contractility, increased dromotropic response, meaning conduction through the heart, and it causes bronchodilation. Those are all things that can help you escape, right? The fight or flight method. And then catecholamines also mimic direct sympathetic stimulation. That's the term that we use, sympathomimetic, right? Catecholamines cause that sympathetic stimulation. Cellular adaptation, I want you to memorize these. I'm going to ask you a question several times this semester to have you identify which stage of cellular adaptation we're talking about. And in this case, there are 6 different stages. We're going to add a 7th one, though, at the end, which we've already talked about, which is anaplasia, right? Excuse me. Anaplasia is where the cell looks nothing like it used to, right? It's completely cancerous now. All right, so normal cells look like this. An atrophy means that there's loss of cell size, right? So when muscles atrophy, they get really small. The muscles don't go away, they get smaller. Hypertrophy, like left ventricular hypertrophy, or like those gym rats who go to the gym and they have the weight belt and all that stuff, like my son does, They get really big muscles, and that may be sexy, but it's not sexy if it's your heart, for instance, that gets hypertrophied. So hypertrophy is an increase in cell size, and that's not a good thing necessarily. Neither is atrophy. Actually, none of these adaptive cellular responses are good in the long term, but they are useful in the short term. Why would hypertrophy be useful in the short term? Well, let's think about that. So somebody has high blood pressure. Over a long period of time, months or years, that really high blood pressure or aortic stenosis or some pressure against which the heart is pumping, the heart is going to start to wear out. So how does it respond? Well, it gets thicker. That hypertrophy from increasing the size of those cells makes the heart stronger and able to keep up with that high pressure state, which sounds great, right? It is for the short term because it preserves the organism, as we say, but in the long term, it leads to heart failure, and that's not good. So these adaptive cellular responses are good in the short term, but not good in the long term. All right. Another one is hyperplasia. This is an increase in the number of cells. And then we have metaplasia, where there's a conversion from one cell type into another cell type. And that's not healthy either. That's a precancerous state. And then dysplasia is disorderly growth, which is consistent with a malignant tumor. And then finally down here we would put anaplasia, where it's just complete chaos. So this is the example of left ventricular hypertrophy. This is the left ventricle here, and that left ventricle is normal in this picture, but up here, look how tiny the cavity is, right? That's because this muscle is so thick. Hyperplasia, again, this is where the number of cells increases, is different than hypertrophy. Hyperplasia is where the number of cells increases, not the size, okay? And this is usually in response to some demand of hormonal stimulation. Sometimes it can be from persistent cellular injury or chronic irritation in the epithelial cell beds. Metaplasia is where you have normal cell tissue that gets replaced by a different cell type. And a good example of that is shown here with Barrett's esophagus. So in Barrett's esophagus, there's this normal stratified squamous cell epithelial tissue. But because the tissue is being constantly bombarded by stomach acid that's leaking into the esophagus, those cells get replaced with goblet cells or columnar epithelium. And the goblet cells replace this tissue because they secrete mucus that protects the cell lining of the esophagus. The problem is that the process doesn't stop there, and there's more cellular change coming because this is a precancerous state. And that's a metaplastic condition, metaplasia. And then dysplasia, of course, is just disorganization, and you can see that it goes through several phases where there's mild dysplasia, where it's just a little unusual, and then there's moderate dysplasia. Later, it goes down through the basement membrane, and that's when the real problem of the invasive cancer begins. When it penetrates the basement membrane, that's the beginning of the end, so to speak. That's the beginning of cancer. Last thing we're going to talk about is sense of self. It's very quick. I want you to understand that I think in every body system, there is a autoimmune disorder that's well known, and sometimes it's multiple systems. One that is very commonly seen in practice is type 1 diabetes. But there's also rheumatoid arthritis, Hashimoto's thyroiditis, and some other ones. These are type 4 hypersensitivity reactions. They are cell-mediated. And the cell that we're talking about is the T cell, all right? The T helper cell. And that T cell is coming on board and causing destruction of the tissue type through an apoptosis mechanism. So we're going to talk about the 4 different hypersensitivity reactions. Type 4 is what happens in autoimmune disease like type 1 diabetes, like rheumatoid arthritis, etc.